Well, good morning again. We shall start this plenary lecture on a very interesting topic, dual disorders, just a concept, which I pleasure to co-chair with my dear friend Professor Tarek Abdelgawad from Cairo, from Egypt. And the speaker, I think he doesn't need to be presented. He is very worldwide in the addiction field, but for those one who doesn't know him, Dr. Szerman is working as a consulting psychiatrist and expert on dual disorders at the Institute of Psychiatry and Mental Health at Gregorio Marañón University Hospital, Madrid. And he has been a member of the Spanish State Council for Addiction for several years. He has done a lot of things. He is president of the WAD, World Association. I think I can finish. He published a lot of articles. And I give him the floor to talk about this very interesting topic. Nestor?
Okay, thank you, Mehdi. Thank you, Dr. Mehdi Paez, for this kind introduction. As you can see, he's a friend, it's mon ami, and thank you for that. Thank you to the organizers, the ISAM board. Thank you to the local organizers, Dr. Fatima El Omari, for this kind invitation. It's a pleasure to be here. I'm very happy to be here. Thank you to all the attendees, friends and colleagues at this afternoon. With the weather, it's very nice outside in Marrakesh. I think this invitation is an opportunity for us to talk about this topic, about dual disorders. And most importantly, probably, is their translation into clinical practice. Okay, I'm going to, no? Yes. Okay, this is the agenda of my presentation. It will be a short presentation, I think 20, 25 minutes, no more. First of all, I would like to try to answer the question that the organizers are asking me, dual disorders as a concept. Second, I'm going to talk about the importance of the dual disorders in our field. Third, dual disorders are brain disease. Fourth, the perspective of precision psychiatry in the field of dual disorders. And finally, from the clinical point of view, what to keep in mind related to dual disorders. This is my disclosure. Okay, I'm going to try to answer the question that the organizer has asked me. Dual disorder, just a concept. A concept is a mental representation that we use to organize, categorize, and make sense of large amounts of information. It provides us with a way to mentally grasp and work with abstract ideas and knowledge. But the term dual disorders allows us to make sense of the presence of addiction and other mental disorders, which is a clinical reality for the majority of patients, not just an abstract idea. What does dual disorders mean? This is the term that we are using in the field of mental disorders to refer to those patients who suffer from an addiction, an addictive disorder, and other mental disorders. It's very important because addiction, addictive disorder, substance use disorder are mental disorders. They can occur simultaneously or even more importantly from the conceptual point of view throughout their lifespan. Given the diversity of terms to refer to this clinical condition from the WDD, the World Association of Dual Disorders, we have made a call in order to achieve a scientific consensus and use the term dual disorders. This paper was published last year. For us, the term dual disorders is not the same as comorbidity, dual diagnosis, or concurrent disorder. And there are more terms. There are not international consensus about this clinical condition. The term dual disorders, or the other terms, are refer to the relationship between two different simultaneous and separate categorical disorders. Dual disorders aims to align with the scientific knowledge that comes from clinical neuroscience and provide a transdiagnostic, dimensional, and brain-based vision. As you know, dual disorders are the expectation, not the exception. In fact, according to recent studies, more than 75% of patients suffering from severe mental disorder also have another mental disorder, such as substance use disorder. I insist, it's very important. Substance use disorder is another mental disorder, a bona fide mental disorder. Of them, only 10%, I think it's less, of patients with these dual disorders receive treatment for both disorders, addiction and other mental disorders. But dual disorder, does it exist? What is the reason for the use of substances by people with severe mental disorders? Are they bored? With all their suffering, do they have to have something for fun? It's a vice? Why do psychiatrists think dual disorders do not apply to them? Or I change, why do addictologists think dual disorders do not apply to them? Okay, this is one example. This is another very controversial topic. Is drug use a cause or effect of other mental disorders? In this case, I apply it to psychosis. This study was carried out several years ago in real time in people suffering schizophrenia schizophrenia, a very psychotic syndrome, plus substance use disorders. Related to alcohol, schizophrenic people or people with schizophrenia drink alcohol after anxious mood and psychotic symptoms, not in the opposite direction. Therefore, alcohol not trigger psychosis. Related to cannabis, anxiety and events perceived negatively by the patient increase the risk of cannabis use. Cannabis use decrease the negative perception of the event, but increase the possibility of psychotic symptoms that you can imagine. There are a lot of scientific research about this discussion, about this debate about what is the first, the chicken or the egg, the addiction or the other mental disorders. In fact, are addictive disorders two different mental disorders? The high prevalence of addiction, of SUD among patients with other mental disorders make it reasonable to explore the assertion that both conditions are in some ways causally linked. People with mental problems seek relief for their emotional, cognitive, and behavioral problems in substances that behave like psychotropic drugs in the brain. Substance use may help people manage their symptoms, but their substance use can exacerbate or complicate their mental health condition. In fact, substance use can also trigger the development of mental health disorders in vulnerable people. Probably this is a key word, vulnerability, vulnerable people. Biological and social determinants of health are recognized factors that contribute to vulnerability to or resilience against developing SUD and, of course, other mental disorders. This paper, probably all of you know it, was published 6-7 years ago, was published in the New England Journal of Medicine by Nora Volkow, George Coop, and Tom McClellan. It was published in order to support the brain disease model of addiction. One of the key points of this important paper are 1 in 10 people exposed to psychoactive substances will develop addiction disorder or addictive disorders. Therefore, individual vulnerability is necessary. It's not enough to have exposed to substance with addictive capacity. As you know, using substances is not the same as having a substance use disorder. This research, this animal research, was published by David Bellin and his group, aims to distinguish between taking substances and seeking substances. Research has shown that the neurobiological processes underlying seeking and taking substances or behaviors are quite different, but do interact. Seeking substances is the predominant behavior of people addicted to drugs. According to the scientific community, all mental functions are based on the brain. Therefore, all mental disorders are brain disorders. This is the reason why this slide doesn't make sense, because there are not different mental disorders that are located in different brain areas. There are some compartment of the brain for addictive disorder and other mental disorders in between dual disorders. During the last decade, most of the neurobiological research on addictive disorder was focused on the brain reward system, on the dopaminergic brain reward system. But we know that all psychoactive substances with abuse potential bind to some endogenous system, such as the endocannabinoid system, the endogenous opioid system, the cholinergic nicotinic system, and so on. This is a simple way to see the problem. As you know, we are living in the era of precision medicine. From this perspective, we have introduced the concept of precision psychiatry in the field of dual disorders years ago. Due to diversity in genotype and environment, one man's meat is another man's poison. The effect of substances are not the same among different individuals, including those of different sex. Psychoactive substances can also have distinct effects depending on the mental state, based, of course, on the brain individual differences. You can see in children, we are giving children with ADHD amphetamines or stimulants, and they are improving. The same substance, the same drug in other children, the effect will be different. Another example, you can see in this slide a cup of coffee, a strong espresso, and two different individuals, two different persons, two different brains. Why some people drink coffee to be more awake and others to sleep better? I can repeat with all the substances, psychoactive substances, this kind of example based on research, of course. This is another example. Nicotine effect is different in schizophrenia and in non-schizophrenia populations. Nicotine administration normalizes hyperconnectivity in people suffering schizophrenia, and the results suggest the high prevalence of tobacco use disorder in schizophrenia may be an attempt to correct a network deficit known to interfere with cognition, supporting the self-medication hypothesis. Why people with psychiatric vulnerability seek psychoactive substances? We can answer the question from the perspective of self-medication hypothesis, for example, revisited from the neurobiological point of view, of course. People with SUD use substances to alleviate underlying emotional, cognitive, and behavioral problems. Or we can see another perspective from Mueller. He has published this proposal about drug instrumentalization theory. Drugs, for him, are consumed in a very systematic way to make other non-drug-related behavior more efficient. Or we can consider the drug of choice model. People may be vulnerable to a particular substance, which is the best self-medication for them. So, people with mental disorders do not seek all substances, but only those that their brain asks for. The self-medication hypothesis is, as you know, is all in the science we are discussing and have controversies. The self-medication hypothesis leads to concern that treating substance use disorder may worsen the symptom of other mental disorders. If this is true, it could mean an important limitation for SUD treatment in patients with other mental disorders, but also open a discussion in the dual disorders field. Since the treatment of SUD can influence the improvement, going back. Can you change the, okay, thank you. Okay, since the treatment of SUD can influence the improvement or worsening of dual disorders, an integrated approach should be necessary. Okay, about the treatment. This headline was published, I think, 8 years ago in The Guardian. The title, NHS is failing people with mental health and substance use problems. It's failing treating patients with dual disorders. I think 8 years later, I think the situation is even worse. According to this paper from Nora Volko and other colleagues, despite the overwhelming existence of neuroscientific and epidemiological evidence that dual disorders are the expectation, not the exception, it is estimated that less than 10% of people with dual disorder receive adequate and integrated care. Lack of attention is driven in part by lack of training of clinicians on how to diagnose and treat dual disorders, as well as by the structural differentiation and lack of coordination between programs to treat substance use disorder and those to treat other mental disorders. This is often referred to as the wrong door syndrome, in which people receive either addictive services or psychiatric services, but not an integrated treatment. Okay, I'm going to the final of the presentation will be about some consideration from the clinical point of view. In relation to the diagnosis, it's important to keep in mind that we can improve the identification of very specific clinical phenotypes or biotypes that are more precise than our current psychiatric categories. A more multidimensional and non-categorical approach to treatment is needed. We need to consider phenotypes, syndromes, symptoms. Upon clinical presentation of an addictive disorder, we should ask, what is the other mental disorder? What is the other symptom, the emotional, cognitive, or behavioral symptoms, and vice versa, of course. In relation to the clinic, it's important to keep in mind that, remember, the effects of substances are different in different people, different individuals, different brains. We need to ask why patients are seeking a particular substance. You need to identify the main substance. People say, oh, I'm consuming alcohol and cocaine, but in the majority of the cases, one of both are important and the other is secondary. What effects are they experience? What the relationship between the substance and other mental disorders is? What symptoms they may be relieving? What symptoms get worse? Some clinical questions. In relation to the treatment, it's important to keep in mind some consideration. One of the main barriers hampering most therapeutic approach for dual disorders is considering addiction a behavioral problem, as it was 50 years ago. However, addiction has been accepted as a brain disorder, likely linked to other mental disorders. With the outdated behavioral perspective, clinicians simply encourage dual disorders patients to quit tobacco, quit heroin, quit cocaine, and other substances. That is like in asking them to stop having depression, quit psychosis. But it's the difference between considering addiction a behavioral problem or a brain, a mental disorder, a bona fide mental disorder. Finally, in relation to the treatment, it's important to keep in mind that we need target treatment that operate on symptoms or syndromes, irrespective of traditional categorical diagnosis. We should consider that what many refer to as harm reduction, or for me it's less stigmatizing term, substitution or replacement therapy. I think it's much better term than harm reduction. we should promote integrated clinical intervention from the biopsychosocial perspective, but in this order, biopsychosocial perspective. Finally, dual disorders, according to Nora Volkow, a recent paper that she has published, should be considered within the context of a chronic care model. Okay, from the WDD, we are organizing our next meeting that will be next spring in Mallorca, Spain, and I would like to see all of you. Please save the date and see you in Mallorca. Thank you so much.
Thank you, Nestor. Thank you very much for challenging plenary lecture, and I'm sure our colleagues here have questions for you regarding the dual diagnosis concept and the questions that you posed. Floor is open for questions. We still have half an hour. Can you please just tell us your name? Can a microphone, yes, please. And your name, just to be introduced. Thank you.
I'm Srijan from Australia. It's more of a comment, and I would like to.
I can hear. Can you?
It's more of a comment, and I would like to get your response on that. I work in a service where the substance use treatment and mental health treatment are widely separated, and so difficult for patients with mental health disorders to access any substance use treatment. And I feel that these terms of self-medication hypothesis and dual diagnosis has kind of made that gap wider. So self-medication could be a reason for someone starting substances, but later on they have developed an addiction disorder, but that's not considered while treating people with mental health disorders, because they feel that I'm treating mental health disorders, so the person does not require substances anymore. And that's kind of attitude that comes up with people who are treating mental health diseases. And this term of dual diagnosis, again, it kind of again separates. It's a single brain disorder, it's a single mental health condition. We do not say dual diagnosis for someone having anxiety and depression, but we do say dual diagnosis in somehow separating those two conditions and consider that they are co-occurring. What do you think about these terms being more kind of widening the gap rather than helping the consumer?
Okay, if I understood, I'm going to start with the consideration of the self-medication hypothesis. The paradigm in treatment in our field of addictive disorder is the treatment with methadone with patients suffering from heroin or opioid use disorder. We need to consider this paradigm to reply this paradigm probably in all substance use disorders. We are in this Congress, in this conference, we are talking about use of stimulants in people who are addicted to cocaine use disorder or stimulant use disorder. We need to get to give nicotine or tobacco heated, because it's different nicotine from tobacco. The effects coming from tobacco are not the same from nicotine. Some people say it's nicotine addictive disorder. No, it's tobacco addictive disorder, because they are different. Okay, I'm going to thinking about we need to reproduce this paradigm of substitute the replacement, the drug that patients are needing for another legal drugs. In order, probably sometimes, I'm seeing here in the room to Angelo Maremani from the north of Italy. I hear some speech from him, some talking from him, that probably opioids are improving psychotic symptoms, and probably psychotic people suffering from with heroin use disorder, but without use opioid use disorder, probably opioids are improving psychotic symptoms, and depressive symptoms, of course, and other symptoms. Okay, I think it's a very controversial topic. Science is controversy, it's not one answer, but I think we need to change. We need to go to think another way, because we are thinking in the same way as the 50 years, considering addiction as a behavioral disorder. And Nora Volkov have stated 20 years ago, addiction is a mental disorder. It's an addictive disorder, brain disorder, sorry. But, okay, all the scientific community have accepted that this statement. But when we are going to treat patients, we say to them, quit. In some cases, it's working, but not in the majority of patients. I don't remember, sorry, the other questions. Okay, I don't know.
Thank you, Nestor. Other questions? Microphone here, please.
I'll start while the microphone's coming. David Jack is my name. I work in Australia, addiction centres. I wonder what your magical thoughts are, your successes with achieving psychiatry involvement in addictive diseases. Because I think that is our greatest challenge. Not all of our addicted patients are engaged with psychiatric services. And so we are happy that we should be looking after their addiction problems, both in and out of hospital. But for patients who are already engaged with psychiatric services, we feel it's reasonable for the psychiatrist to look after the addictive problems. What are your solutions? How have you achieved this psychiatric buy-in?
Okay, if I can answer your question, I probably am going to receive the Nobel Prize. We are living in separate worlds. Psychiatrists in one world and addictologists in another different world with the Rondor syndrome. It's not psychiatrists in my own hospital say, oh no, Nestor, they are addicted. It's not a mental problem. And on the contrary, and the addictive services, oh, he's psychotic people. We can have the theories, or we can know how to use some drugs in order to treat psychotic symptoms. But with the same example that I gave before, some drugs, buprenorphine, is treating different mental disorders. Probably depressive disorder, borderline personality disorder are improving a lot with buprenorphine. And psychotic symptoms, and people with impulsivity are improving with stimulants, and with gambling disorder, here is Mark Potenza, I don't know, with stimulant, but there are trials with opioid antagonists, different, namelfen or naltrexone, but probably with cocaine or not cocaine, and stimulants, lisdesamfetamine or another stimulant, are improving gambling disorders. Not all of them, but probably the majority of them, or some phenotype of them, because we need to consider mental illness not from the categorical point of view. Some people are talking about depression, but what kind of depression? Is inhibited depression or impulsive depression? Because people with suffer gambling disorder, most of them suffer depressive symptoms. But what kind of symptoms, depressive symptoms? Depression with impulsivity is not the same that depression with inhibition. Okay, there are different considerations, but we have a problem. And the last paper that Nora published in the World Psychiatry 2 years ago, I think so, is considering the problem of dual disorders, not the lack of training of new psychiatrists and people to know about dual disorders. Nobody in my own hospital my residents, it's difficult for them to understand how to give buprenorphine our patients. No, it's not how works buprenorphine. It's basic knowledge. Okay, our field is open to discussion.
Yes?
S'il vous plaît.
Is there.
My name is Carl Drogreif Fiskon from Norway. First of all, thank you very much for an excellent presentation. I have some, maybe more of a practical question. It was intriguing what you said in the end about agonist treatment or substitution treatment. And I'm working with inpatient addiction, and what we often see is the discussion with the psychiatrists and when can you make a diagnosis? Because what's first? Is it a depression related to alcohol use, or is it a depression and alcohol? And we discuss how long time do they have to be without substance use to make a diagnosis. So I would like to hear how do you get around this problem?
Okay, we need to treat together in an integrated way all the symptoms, not of just of disorders, all the syndrome, the symptoms, the personality, pathological traits that people are suffering. You are mentioned to depression and alcohol use disorder. It's very common presentation or clinical presentation. We are having new published publication, new research about, for example, the use of ketamine or sketamine, or another, probably the new hallucinogens, psilocybin, in order to treat both depression and alcohol use disorder. We need to think together, not what will be the first. Okay, the patient needs some, in the case of alcohol, some desintoxication, because detoxification, sorry, because they are drunk, of course. But we need to treat together and think together. But there are different symptomatic expression of the brain, of the same brain alteration, the same brain disorder.
Yes, sir.
Thank you very much, Nestor. Yasser Kazal from the Eisen board. I think we are talking about a critical point. There is such a huge gap in the way people treat the concomitant disorder in different clinics, and such a huge gap in the way they see how they have to organize their services. Maybe we need a consensus or a recommendation about how to treat together, how to treat this condition, how to organize services to get the services people needed, how to focus on the common pathway that underlie at least partly the disorder. What do you think about going for such a recommendation?
For social? Sorry?
Yes, I think in the clinical way, you have so many views, so many opinions about how to do it. About it's the work of someone else, about it is not my work, about how to conceptualize the concomitant disorders. So many discrepancies worldwide, including in Europe, and so how to, maybe we need, it's a huge issue, the issue you are talking about, and maybe we need to go further, not to say only we need integrated treatment, but to say how, when, how to organize services, how to assess the quality of the services that deal with this issue, how to integrate the common pathway like emotion dysregulation, impulsivity, other kind of common pathways that partly explain part of the. This is a question rather to have your input about that. Do we need something like that?
Okay, thank you for your consideration. I think a long history behind psychiatry services and addictive services, and it's very difficult with a long history, different philosophical hypotheses in both fields, it's difficult to unify. We need to change the way to think. We need to consider no diagnosis, no categorical, to consider syndromes. It's more easily. With my resident, I always said, okay, you need to learn the DSM-5. Oh, doctor, but you are telling that we need to consider symptoms or no, you need to learn DSM-5. After you learn the DSM-5, you study DSM-5, we can criticize and we can consider from the clinical point of view every patient in different ways. What kind of patient is, what symptoms they suffer, what drugs, what substances they are consumed, why, what is the effect of these substances, are not the same. The people with ADHD, stimulant are improving them, but it's not, cocaine is not the right treatment, or not amphetamines. Probably we need to change to legal consideration. But to unify the two networks, addictive services or addiction services is very difficult. Starting with all the expert, the professional that are working in the psychiatrists who are working together with me, no, they're refusing to treat addicted patients. Oh no, we are a very clean psychiatry. We don't like it to see this kind of patient. In the other network, in the other services that are treating addicted, they are not psychiatrists. And we are, in the Western country, we are having a big problem because we are having psychiatrists. It will be less and less during the last, probably, during the following year, sorry. Okay, we have a problem, but we are here working together, having this Congress with ISAM leaders, and we are treating this kind of discussion and in order to improve the attention of our patients.
Good afternoon, my name is Madhu Sukai. I'm a psychiatrist from the Netherlands. I beg to differ a little bit. I'm a psychiatrist, and in the Netherlands, we have addiction specialists. I have very little expertise. That's actually why I came to this Congress, because I feel like we as psychiatrists need to also have knowledge on addiction and be able to work with it. But I fully agree with the previous gentleman, his suggestion, because I think that is where it maybe lacks, because I hear you saying a lot of very interesting things about, for instance, nicotine use. Like we psychiatrists say maybe very easy, like you have to stop. But here now I gain the knowledge that maybe that's not the best idea, but I don't know then how to go further. I cannot find any guidelines on how to treat them together. So I would love for there to be some guidelines to work with. So if ISAM could provide those, or I don't know, work on it with experts in the field, that would be great for psychiatrists.
Thank you for that. It's true that we haven't guidelines. Probably years ago, we have from the WDD we have signed an MOU with ISAM and WDD. Probably could be a target, Mark and other leaders of the ISAM to get together some guidelines in order to treat dual disorder. But it's very difficult because the evidence are very poor. The guidelines are based on evidence. As you know, evidence are poor, are very few of them. But we need to move forward in order to get the assistential community some guidelines or some expert recommendation. Probably will be much better than guidelines.
Yes, thank you. I agree with that. But I do think if there is any expertise on it, on what the latest situation is according to research now, then you know, that should be available. Because if it's already difficult for the experts like you, then let alone for a mere psychiatrist like me who has to deal with these patients in practice. So it would be very helpful.
Totally agree with you.
More questions? Comments? I think we have in this room experts and representative of international organizations. If any one of them would like to contribute, Professor, yes, Mark, please.
Thank you for the talk, and thank you for the question. And I do think that it is important to develop guidelines. And how best to do that with the existing data can be debated. So I'll take a small piece of that. As I've been working with people with gambling problems for several decades. So what we have tried to do in these circumstances is to generate proposed algorithms to help people individualize care and treatment, both for pharmacotherapies and behavioral therapies. So we've developed algorithms based on existing data, based on co-occurring disorders in many instances, as to what we would recommend given the existing data, and given that there are no medications that have a formal indication for gambling disorder, but there are medications that have indications for people with other conditions that frequently co-occur with gambling disorder. So I could direct you to some of those articles. Probably the most recent one is in Nature Reviews Disease Primers in 2019 in an article entitled Gambling Disorder, where we have a relatively complex treatment algorithm that's based on severity of illness, co-occurring disorders, and which behavioral and pharmacological therapies we would recommend given the existing data, which we think has significant gaps. So that's a small part of it, but bigger concerns in other areas, because gambling disorder may be a small proportion of individuals who you see in treatment. There are many other conditions for which a similar approach could be taken and proposed guidelines recommended.
Vladimir Poznik, World Health Organization. Thank you very much indeed. This presentation raised a number of complex questions, but let me address the issue about the guidelines and what to do. First of all, I think it may be exaggerated too much, the problem of treatment protocols for comorbid conditions. Because if, for example, you have a patient with schizophrenia, bipolar disorder, and at the same time the same patient has a nicotine dependence or has some other substance use disorder, yeah, you can. Of course, it's a bit different from just treating patients with isolated disorders. But you can apply the same pharmacotherapy for nicotine dependence, for example, with the same patient, of course taking adjustments for interaction of medicines. And when it comes to the objectives, of course we know well that a self-medicating hypothesis is a very valid one. We also know that it was described in the literature a long time ago that, for example, patients with schizophrenia, which have heavy drinkers, they have less prominent negative symptoms in their life course. But at the same time, when we look at the treatment outcomes, what you want to achieve, you don't want your patient with schizophrenia to die from lung cancer and 55 years old, right? So even if this patient would feel a bit better in terms of psychological comfort or well-being, right? But you need to prioritize the treatment outcomes which can increase lifespan and decrease morbidity and disability of this patient. When it comes to the guidelines, yes, there is definitely need for these guidelines, and I think you're absolutely right, Nestor, that the evidence is relatively weak. But at the same time, let me make one point. It's not absolutely necessary to have a strong data for developing guidelines. Of course, the strength of evidence would be different under recommendations, but these recommendations can still be made. And I think, indeed, the need for such guidelines is clear, because this is one of the complex issues which clinicians deal with. But I expect that the biggest problem in these guidelines would be related to recommendations on service provision, because it's so much context dependent. It so much depends on what are the systems of organization of mental health, psychiatric, and addiction services in the countries, and overall organization of services. That would be the most challenging part. And still, I think I would agree that these guidelines has to be developed. And of course, I cannot say anything, I cannot make any commitments at this point, but this conclusion or this request for developing guidelines is well taken, and I will bring it back to my organization. Thank you.
Thank you, Vladimir.
Thank you. I think there are a lot of problems in our field, in both fields. It's the same field, addiction and other mental disorders. We are living, I told in my presentation that we are living in the era of precision medicine, but we need to consider this new perspective of precision medicine in order to get personalized treatment. Patients with schizophrenia, how many kind of people, how many type of schizophrenia exist? According to genetic point of view, I read some paper that there are 8 different kind of schizophrenia. We are talking much better about psychotic chronic syndrome, but psychotic chronic syndrome is present in different mental disorders, in bipolar and OCD and severe borderline personality disorder, in different mental disorders. We need to consider personalized treatment. We are expecting to have in the following years biological markers, genetic markers, in order to identify how many patients with schizophrenia are suffering at the same time alcohol use disorder. There are a group of them, but there are probably different phenotype than other patients. And the main drug that people with schizophrenia consume is tobacco. Not nicotine, because nicotine is one of the components of tobacco. The tobacco have another unknown product that are creating, for example, in MAO inhibition and giving antidepressant effects for people. But they are improving, nicotine is improving cognition, is improving different symptoms that people are consuming. It's very difficult to get that people with psychotic chronic syndrome quit tobacco. When we ask them, would you like to quit tobacco? Oh, yes, doctor, I would like. But not at the moment, next year, and next summer, because it's very difficult for them to think and to quit. The last consideration, and sorry for, is about the clinical guidelines. How many people, probably here, most of you are a clinician, how many of you are consulting guidelines in order to treat their patients? Say, okay, one, two, okay. Congratulations. But it's not. Okay. But it's very difficult because guidelines is not supported, it's evidence. Evidence are in our field with the same paradigm that the same consideration of categorical diagnosis in psychiatry that came from the Kraepelin times 1 more century ago. It's very difficult to treat and to diagnose people with mental disorders. Okay, I think it's a fascinating time in order to change our thoughts.
Before I hand over to my dear friend and colleague, Professor Mahdi, may I ask you how many of you working in integrated services or addiction psychiatry. Majority, Nestor. That is very good. But then again, I believe the need for guidelines, since we all are working in a kind of integrated services, is very much needed, because this is what we are facing. Thank you, and I hand over to my colleague Mahdi.
Well, thank you. Thank you, Nestor, for your very interesting presentation, and thank you to the attendants for your interest and for your presence. And I think that we can stop this session, and I wish you a good lunch.